Ethnic and racial differences in the prevalence of vascular disease exist. Over the next few minutes, I'm going to show you some of the evidence, including the genetic and vascular biology basis for those variations, as well as the differences in the prevalence of vascular diseases, but more importantly, in risk factors. I will discuss also the limitations of the current studies and recommendations for future research projects. I want to emphasize, however, that the knowledge we have today is still insufficient. A minority health summit sponsored by the American Heart Association in 2003 concluded that there are major racial and ethnic differences that influence the natural history of cardiovascular disease. These differences are genetic, environmental, socioeconomic, and cultural. There are also differences in healthcare services and access disparities. Although a fairly small number of genes describe appearance and there is no basis in the genetic code for race, there is evidence of genetic differentiation between ethnic and racial groups. In fact, allele frequencies for polymorphisms differ 15 to 20% between racial and ethnic groups. Genetic determinants of vascular diseases are still poorly understood. Some have been, however, established, such as the frequency of factor V Leiden, which is present in 5% of whites, but in less than 1% of East Asians and blacks. Race-specific differences in endothelial function have been established and may account for the increased risk of vascular disease in blacks. Very few of these studies, however, have included Hispanics. Cardiovascular disease is the main cause of mortality in the United States in all racial and ethnic groups. However, there are well-established differences. White men and women have significantly lower death rates compared to black men and women, respectively. Now, there are also significant differences in the prevalence of risk factors for vascular diseases. In the Dallas Heart Study, black men and women have significantly higher prevalence of smoking, hypertension, and diabetes compared to white men and women. HDL cholesterol levels were also significantly lower in blacks compared to whites. The multi-ethnic study of atherosclerosis also revealed that blacks and Hispanics have a higher prevalence of obesity, diabetes, hypertension, and low income compared to Asians and whites. The atherosclerotic risk in communities study further revealed that clustering of risk factors, that is, the presence of two or more risk factors in the same individual, occurred more frequently in blacks compared to whites. As shown before, this recent observational study that included data from 7 large population-based studies in the United States revealed that with increasing age, men have a significantly higher prevalence, black men have significantly higher prevalence of peripheral arterial disease, or PAD, compared to other racial and ethnic groups. Among women, both blacks and Hispanics had significantly higher prevalence of PAD. Several other studies have also assessed the outcomes of vascular interventions for peripheral arterial disease. All these studies have shown consistently worse outcomes among blacks and Hispanics. There are also significant differences in the prevalence of carotid stenosis. This observational study that included 1,000 carotid duplex scans revealed that Hispanics have a lower prevalence of moderate and severe carotid stenosis, whereas whites had the highest prevalence of severe carotid disease. Although most studies have compared primarily whites and blacks, recent studies have focused also on outcomes of vascular interventions in Hispanics. This population-based study that included data from vascular procedures performed in New York, in Florida, from 2000 to 2004 revealed that Hispanics had significantly fewer lower extremity revascularizations, carotid revascularizations, and AAA repairs. Conversely, Hispanics had a higher number of amputations compared to whites. So there are differences in vascular disease among ethnic groups. Current health policies, including the Healthy People 2010, are focused on improving health care and quality of life for all and eliminating health disparities. However, to accomplish those goals, it's very important to establish the natural history, the treatment, and the prevention of vascular diseases among minorities. Unfortunately, current studies have several limitations. Minorities are not studied or underrepresented, primarily because of limited access to health care. In fact, study populations are most studies are not community-based, and inadequate screening tests have been used. Is there a better approach to assess vascular disease in minorities? Community-based participatory research may be a better option. In this model, the barriers are overcome because we access the community directly. This model brings community members as partners, not just subjects, and uses the knowledge of the community to understand health problems and to design interventions. As an example, our institution in Dallas has partnered with several community-based organizations, such as the Dallas Consilia, not only for education and service, but also to work on research projects, such as this one, in which we're trying to assess the feasibility of detecting PAD and associated risk factors among Hispanics. We're also conducting a randomized clinical trial to compare community-based, supervised exercise and risk factor modification programs versus usual care. So in conclusion, there are differences in prevalence, natural history, treatment, and outcomes of vascular disease, although these are not well established. Most differences are related to genetic, socioeconomic, and cultural factors, although limited access to health care may account for most disparities in vascular care. Further studies are needed in which representation of minorities need to be promoted by community-based research. The natural history of vascular disease needs to be defined for each racial and ethnic group, and the complex and dynamic interactions between race, ethnicity, genetic, social, and cultural factors need to be explored in regard to vascular risk to guide prevention and treatment. Thanks again.